the second floor of this building. It's the boardroom that you have to go in for the evaluation, and the posters will be evaluated by Dr. Ravi Gaur, Dr. Gayatri Mahindru, and Mr. Vijay Simha. Thank you, Dr. Jairam. Please take the session.
Thank you, Shilpa. I guess it's good afternoon already. Good afternoon, everybody. And we are now well on our way on the keynote session. I'm actually taking the place of my very dear friend and colleague, Dr. Narayan Puri, who was to moderate this session. And due to the reasons of the virus that has hit so many people, unfortunately Dr. Puri is not here this morning. So I have the privilege, therefore, of moderating this session. Let me introduce the speakers and then we'll be on our way. On my right, and as is appropriate, I'll introduce the lady first. Aarti, who many of you know and I know very well, heads medical quality across Max Healthcare Group of Hospitals. She's also the Secretary of the Medical Excellence and Compliance Committee of the Board and Secretary of the Pan Max Infection Control Council. She's also a very active member of the NABH and chairs the Technical Committee for Clinical Standards and the co-chair of the Technical Committee of NABH. She's graduated in 1981 and served in various clinical and administrative positions, including the Army, private sector, and the strategic health authorities in the NHS UK. She's also responsible for the nursing reforms work that was just published. And Aarti, welcome to this morning, and thanks for being here. On my left is Professor Stephen Sisson, Professor of Medicine and Executive Director, Ambulance Services of the Johns Hopkins Hospital in the United States. Prior to his current role, he has served Johns Hopkins in many positions and has served on many associated committees, work groups, and task forces. From 2011 through 13, he chaired the Johns Hopkins Clinical Practice Association Compliance Committee, and he was also the Vice Chair Clinical Operations for the Department of Medicine. He obtained his medical education at the Tufts University School of Medicine, following which he completed internship residency and chief residency at the Johns Hopkins Hospital. Thank you, Professor Stephen, for being with us this afternoon. And on my extreme right is Colonel Avinash Seth. I always believe the people from the armed forces prefer to be referred to by their title and not doctor, and therefore I called Dr. Avinash Seth Colonel. He's Director of the Fortis Organ Retrieval and Transplantation Service and Director of Gastroenterology and Hepatobiliary Services of the FMRI. He's actually been a pioneer in organ donation after brain death in the North and Director of the FORT, which is Fortis Organ Retrieval and Transplant, and earlier the Founder Director of the Armed Forces Organ Retrieval and Transplant Authority. He established a successful liver transplant program at the Army Hospital and was awarded the Vishisht Seva Medal by the President in 2009. He was the governing member of the Indian Society of Gastroenterology and Society of GI Endoscopy and has 100 publications to his name. An alumnus of AFMC, he completed his MD from Pune and DM Gastroenterology from PGI. Welcome. So, without further ado, let me now ask Aarti to talk about what she has done in terms of the work on nursing reforms in India.
Good morning, everyone. I hope the mics are working. Yeah. Good afternoon, everyone. My correction. Firstly, I would like to emphasize here that I am standing here on behalf of the nursing task force, which was set up by FICCI 2 years ago. and I represent whatever I'm speaking, I'm representing their voice. We have some members here, Usha Banerjee, Bimla, Thankam, Vijay. Thank you all. Also a quick thank you to Shobha, whose continuous inspiration has pushed this forward. Dr. Jairam as the chairperson, the Indian Nursing Council, the Ministry of Health, all the other members of the Nursing Task Force, my esteemed CEO, Mr. Rajat Mehta, who's an extremely inspiring leader and continuously pushes us to explore higher and higher horizons. The report of the nursing reforms is there in everybody's folder, and we urge you to kindly go through it and welcome your feedback so that we can continuously improve on it. So in the next few minutes, I'll just give you a few highlights of what we have covered in the report. We've all reiterated in the morning session also, we do believe nurses are at the center of patient-centered care. And ideally, they are the people who are actually delivering care. The most important people in the healthcare delivery team are the nurses. There's a quote by an unknown, save one life and you're a hero, save 100 lives and you're a nurse. So hats off to all of them, our compliments to the commitment and devotion that nurses are displaying and demonstrating every day in our healthcare system. Some of the issues that have been highlighted when the task force went into a deep dive to really get an understanding of where we are, we highlighted the fact that there's a huge demand-supply gap. There's a lag in healthcare spend overall. We have a lag in inadequate infrastructure and obviously an insufficient workforce. By the way, nurses are the largest volume of the healthcare workforce in any system. The stipulated nurse population ratio is 2.5 to 1,000, and whereas the current one is we are only at 0.7, and we need an additional, as on date, 2.4 million nurses additionally to serve our population in our country. On the other hand, we have a demand of growing demand for healthcare, increasing burden of disease, and increased healthcare needs of our population in terms of service. The nurses' numbers have been growing quite a lot. So we have a lot of nurses coming out of our colleges. We have nearly 300,000 annual nursing seats. This information is thanks to the Indian Nursing Council. However, this is not able to, while we see an exponential rise in the number of nursing colleges coming out and the number of seats that are approved by the Indian Nursing Council year on year, but still this is lagging behind the population needs of our country. So again, I repeat, we need to have 2.4 million nurses additionally. So the opportunity to set up nursing educational institutions is huge, and I'm sure it also makes a very good quality and business sense. We also did a SWOT analysis. I'll quickly run you through. The strengths of nursing profession is that there's going to be a continuously high demand for nursing, both in India and internationally. There's a growth in the nursing institutions. There's a demand coming up from major chain of hospitals, research centers, and educational institutions. And nursing as a professional, as in healthcare, will always have immunity from any recession or any economic downfalls. Some of the weaknesses we highlighted: lag in supply versus demand, an uneven distribution of nursing colleges across the regions. There's more focus on the south and less on the north. Competitive compensation is missing, so it's losing its appeal as a career choice for students who want to decide what profession they want to take up. There are fewer opportunities for higher nursing education, so if a person wants to exploit their potential and rise in their career, there's not much options for them. Related to that, lack of well-defined career paths for nursing within our industry, a very low investment in nursing research and training, lack of coordination between the healthcare delivery system and the academic institutions, and the curriculum and the competence that our nurses are being given in all these educational institutions. Again, there's a gap between what the healthcare delivery system and the customer demands today versus what the academic world is churning out in terms of specialized skills, matching the burden of disease. We know that India is going to have a huge burden of oncology. So, do we have oncology nurses available? Do we have nurses who are specialized in cancer, in heart disease? Do we have more community nurses coming out? So catering to the burden of disease, we don't have paths where the nurse can actually be qualified to take care. their orientation to quality and safety, use of technology within their systems, some cultural issues on language, because there's a skew of where the nurses come from, leadership positions, and overall within the hospital hierarchy and within the healthcare hierarchy. It's sad to note that the social status that we attach to nurses is quite low in the profession. So they're pretty low in the hierarchy of within the healthcare system. They're not represented at very many policy forums, and there are very few organizations. I would be proud to say that organizations like ours, Max Healthcare, we do empower our nurses and we give them very high platforms, but that's not the case across the country. We don't have nursing representation, say, at the state government policy level. They're hardly represented. The nursing function is being led by another officer, non-professional, non-nursing professional. And the stressful environment sometimes they have to face in terms of is not suboptimal for them. However, looking at the positives, there are huge opportunities for them. Upgradation of curriculum and faculty so that we can ramp up and meet our modern day nursing requirements. Can we shift to a competency-based education? Can we introduce more nurse practitioner courses? Increase the investment in nursing education, and litigation are going to be the order of the day, and nurses are also going to be victims of this. And low GDP, overall low GDP allocation to the healthcare industry, which is also going to hit nursing. So the task force has set down 30 recommendations, which we hope that all the important stakeholders, policymakers across the country will take these up and convert them into actionables. I will not go through all of them, but we urge you to, in detail, they are specified in the report. But the broad areas are: we need to relook at the INC and its functioning. We need to relook at curriculums and upgrade them. We need to relook at faculty and the way they are developed. We need to have more faculty and actually benchmark and learn from better countries where they're able to do good faculty development. Introduce more empowering roles for nurses, which I think will be a most cost-effective solution for our country. So we should have nurse practitioner roles in every possible area that we can. Rationalize the number of nursing institutions according to the states. And from an education perspective, as of today, there is not even a proper register, at the state level or at the national level, maintaining the accurate number of qualified nurses in our country. So the data is also not updated. I think a system is, INC is already working on this, and soon they should be having this. At the nursing service level, some of the issues that we feel are important. There should be a review of compensation to make it competitive and comparable. Strengthen in-service education and e-learning courses for the nurses. This could be done at a national level by taking help with HSCC and other agencies involved. Look at more public-private partnerships in education and for the academic clinical partnerships. Can we look at standardization of nursing procedures at a national level, at a state level, giving them evidence-based protocols for good nursing care? This is a huge opportunity. Today, there's hardly anything available. We would like to integrate NABH into everything that happens, whether it's a teaching hospital and whether it's at least the nursing excellence standard should be applicable for any hospital that is applying to become a nursing teaching hospital. Some of the nursing experts have suggested that a Nursing Practice Act should be looked at by INC, where we look at credentialing and clinical privileging for them after, in terms of licensing, rather than looking at just academic qualification. Look at more systems for human resource management, given the huge numbers that we have in our country, and this can be done at a state level, and introduce some aspects which are mandated in terms of nursing welfare, so that their social infrastructure is also bare minimum things are catered to. Mid-career and growth opportunities should be identified, and I think at the healthcare industry where we belong, we should be taking up initiatives to actually action this without waiting for policy. On the administration, leadership and management, there is an urgent need that nursing representation should be encouraged at all leadership levels, both at government as well as in private. Nurses should be prepared for taking on more empowered and decision-making roles. There should be proper academic preparation for them in this regard. Have structured performance review and management systems for the nursing profession at large. Look at exchange programs to promote leadership in nursing. Many countries have succeeded with this, such as Japan, Thailand. They've had some excellent examples. And overall, look at a progressive and rewarding career pathway for nurses. The last bit is on accreditation and research. We are also recommending that we set up centers of excellence for accreditation of nursing services. Look at setting up a nursing cell in the ICMR with adequate funding to empower them to look at nursing related improvements in the healthcare delivery system and facilitate more and more current research coming out of the nurses. I think in my concluding slides, a political will is something that is extremely important. So we need to strengthen our regulatory capacity, both at the national and state level, and we need to strengthen the health system and nursing management system, which is in our hands, the private and the government healthcare delivery systems. I'd like to acknowledge once more the FICCI's Task Force on Nursing Reforms, who have deep dived and done a lot of research. I have given you just the highlights, but we have about 40-50 pages of technical and good information in the report. Please do read it and give your inputs on this report, which will help us. So these are the members of the task force. The task force was very diverse. It was integrated. It was not a silo working. So we had representation from all parties, right from ministry, the Indian Nursing Council, healthcare leadership from government, healthcare leadership from private industry, NABH, nursing professionals who are leaders in their own domain. And we had a very vibrant group, practicing consultants who have actually contributed to their perspective on how nurses should be helped out. The E&Y team who has worked with us. And more importantly, Sarita from FICCI, who has been the backbone and helping us day and night to put this report together. Thank you so much.
Thank you, Aarti. I didn't consider it possible to concise the entire thing in the time that was allotted, but thank you for doing a wonderful job. All of us have, I think, understood for many years the issues that plague the nursing industry, but we've not been able to address it because of the regulatory and other issues. And I'm sure each one of us appreciates the effect of attrition on our patient safety and other outcomes that can happen as a consequence of nurse absence or nurse inadequacies. Addressing this is indeed something which is of tremendous importance, and I'm sure with this release today and the fact that the government is appraised of it, we should see the way forward very soon. And I'm sure FICCI will take this up as a strong focus. With that, let's move on to the next topic. And for the benefit of all concerned, we'd like to stick to time. Shobha is seated right in front of me.
Hello.
And has assured me that I should not hesitate to ring the bell in a literal sense if time is exceeded. So pardon me, that was Shobha's decision, not mine. And we should finish this by 12:45 p.m. and I will definitely ensure.
Okay, is the mic on? All right, I do see that Dr. Jairam was equipped with that bell, and he was checking his watch, so I will try to keep us on time here. So we're going to talk about actually the triple aim, which I will explain in just a minute. It's been interesting listening to the talks that have gone before me, and Dr. Desai and I were sitting up there in the speaker row, ticking off how many times the triple aim was mentioned by the first round of speakers. So you're going to see that this is actually in many ways a recap of what you've already heard. So we're going to also talk about re-engineering Indian healthcare and what's going on between Johns Hopkins and HCL, which will be my concluding slides. We're going to talk about what the triple aim is. Again, you've already heard it. You just haven't heard it called the triple aim. And we're going to talk about the role of primary care in achieving that triple aim and how, again, how HCL and Hopkins are collaborating to meet that triple aim. So we've heard a list of some of the issues that India's healthcare faces including not only who is paying for health care, but the shifting of disease burden from communicable diseases to NCDs and how that affects the expense of health care. We've talked about the expansion of tertiary and specialty care, and there's a big gap actually in delivery of primary care, and also the fragmentation of the healthcare system. These are all challenges that we face in the states as well. So what we're going to do is talk about the triple aim and what that has meant to us in the United States and how that may impact future directions here in India. So the triple aim, that term actually came to being in 2008 when Don Berwick, who is a thought leader and a former director, interim director of our Medicaid and Medicare services, wrote this article about trying to improve patient outcomes and patient satisfaction while lowering cost. And that was called the triple aim. And you're going to see as I talk about the triple aim that each one of these is dependent on the other. So as I talk about patient outcomes, you're going to see that I'm going to slide right in to cost. And when I talk about patient satisfaction, I'm going to talk right about patient outcomes and cost. And then when I talk about costs, I'm going to talk about outcomes and satisfaction. So they are all very intertwined, but I'm going to format this speech on dividing them. A narrower view, I run the outpatient center, which sees 500,000 visits a year in multi-specialty care at Johns Hopkins. And when we're deep into the operations of the issues that we face, it's treating the right patient at the right place, at the right time, and at the right cost. So let's talk about the triple aim, and I'm going to divide this into the three sections. So let's first talk about improving patient outcomes, and why is primary care relevant in that? So first off, how are we doing in the United States with delivering primary care? This was actually a study done a few years ago in the United States looking at different outcomes in delivery of care, preventive care, acute care needs, and chronic care needs. And you can see, I don't have a pointer, but you can see that our average score is very much in the middle. 50% of targeted goals in delivering preventive care, acute care needs, and chronic care needs are met. And so we really have plenty of room for improvement. And so how might we actually improve these patient outcomes? Well, that was addressed in this seminal study by the Institute of Medicine at Johns Hopkins called in a white paper which was titled Crossing the Quality Chasm. And in this white paper, the Institute of Medicine made several key recommendations for improving outcomes in healthcare in the United States. And one of their key recommendations was that clinical care should be based on continuous healing relationships. So that continuity of care is very, very important to improving health outcomes in the population. So what are some of the benefits of a continuity of care model? And you're going to see I'm going to switch right into cost, even though we're talking about outcomes. So hospitalization rates for primary care conditions are higher, of course, in areas where access to primary care is limited. And on the opposite side, the more primary care providers you have, the lower the cost and the better the quality. So look at this slide. This is a nightmare slide to the U.S., to healthcare payers in the United States. So in this slide, it's actually graphing quality of care versus cost. And as you move to the right of the x-axis, cost goes up, and you would expect that health outcomes and quality of care would go up. But what you see is exactly the opposite. You see exactly the opposite. Higher expenditures associated with lower quality of care. And so then the next question was, why was that? So they looked at the penetration of primary care in these different states, so these different markets, and whether or not the penetration of primary care was associated with lower cost and better outcomes. And lo and behold, a lot of the circles in the upper left corner of this, you can't really see it here, but they're green. And those are areas, states, where there is greater penetration of primary care, higher quality, and lower cost. So this slide suggests that the greater penetration of primary care you have, the better the outcomes and the lower the cost. So 2/3 of the triple aim. So another area that's been a big focus in the United States is the introduction of the concept of the patient-centered medical home. And I boxed in the key words from what the key features of a patient-centered medical home is: coordinated care, access to care, and communication. And you're going to see all of those come up in my later slides. So let's talk about access, which is part of a patient-centered medical home. So what is the role of access to care? Well, access to care definitely impacts patient safety. If you can't get access to care, your clinical condition is going to deteriorate. Patient satisfaction, definitely associated with access to care. And as far as cost, with good access to care, you are maximizing the capacity that you have to deliver the care to the patients that need it. So the access puzzle is actually a very straightforward question. How do you get the patient who has disease X scheduled in an appointment to see the doctor that treats disease X? And that actually can be a very difficult challenge for a health system. And there are different areas of opportunity to fix in both the scheduling process and the patient and the providers, whether or not you have the capacity and the access. But it's more than that. It's also not only just scheduling, it's the geography. Is the patient physically proximate to where healthcare is delivered, or do they have to travel great distances? And also coordination of care across the subspecialties, also very important components of access. So let's move on to triple aim number 2, which is improving patient satisfaction. The key domains to assess in patient satisfaction, and these are areas that we're focusing on at Johns Hopkins, are timely appointments, care, and information, access to those. So outside of the office, that is access to the appointments. And inside the office, that's actually wait times, a key driver of patient dissatisfaction at Johns Hopkins. And also communication with patients, both outside the office, which means the patient can get in touch with their provider with questions or concerns, but also inside the office. Does the doctor actually listen to the patient and communicate and explain things and show respect? And wait times, showing respect and listening are what we call halo items. If you perform poorly on any one of those, it will drag all your patient satisfaction scores down. So in other words, not only is it patient satisfaction, but we know that patient satisfaction also equals patient safety. The number one reason for malpractice in the United States in ambulatory care visits is failure to communicate, failure to review and communicate about abnormal test results. Number one cause of malpractice in the United States. So you can see how communication, which is a big driver of patient satisfaction, is also related to patient outcomes. So what we use in the United States to track outcomes are 2 different surveys. The CG-CAP survey, which surveys how often things are done, and there are certain things that a health system should define as always happening, things that should always happen with a clinical visit. And then Press-Ganey, which actually surveys how well things are done, and we look at those very closely. This is one of our dashboards where we are looking at not only patient scores on access, but communication, test follow-up, and global provider ratings. And you can see we are aiming right now for just the 50th percentile on our national standards. And in 6 of these 7 metrics, we are below the 50th percentile. One of those, which is test follow-up, has been an area of focus at Hopkins, and you've seen that we flipped that from red to green, which we're happy with. But patient satisfaction is a big driver now, and we know that it impacts patient outcomes and health and costs. So the final part of my presentation is about lowering system costs. And in the old days, when I was an intern, we had already specialized clinical delivery of care based on a model of pairing resources with patient needs on the inpatient side. So the sickest patients wind up in intensive care or progressive care. Then we have specialty wards and then general wards. In the ambulatory environment, you were either in clinic or you were in the emergency department. And the emergency department is a very expensive place to deliver outpatient care. So now you see what has happened in the United States is that we have actually diversified the number of offerings in ambulatory care. So we have retail clinics, standard ambulatory clinic, infusion clinic, and the emergency department. We also have observation units where the patient is observed for extended periods of time. So I want to talk just very briefly about retail clinics, which are really having an interesting impact on healthcare delivery in the United States. So these are walk-in clinics, no appointment necessary, delivered inside a retail activity. So our Walmart, which is a big general services vendor of different supplies, and Walgreens, which is one of our big drug pharmacies, have clinics inside their department stores and pharmacies. And what they do is they deliver usually acute care needs, usually for minor illnesses. They have extended hours, and they use nurse practitioners or physician assistants, so the cost of care is low. So for instance, if you look at this, the first line in this table, you'll see that the total cost, so this was a study looking at, let's say a patient comes in with a common cold, and they're seen in a retail clinic versus on the right side of the slide if they're seen in the emergency department. In the retail clinic, the average cost of care was $110, whereas in the emergency department, it was 5 times that. It was $570. And so it really shows that and the quality outcomes were actually the same. So if you look at where you want to spend your resources, you want to spend them in a retail clinic rather than the emergency department. The problem with retail clinics is that we've actually done some studies that show that it disrupts continuity of care. And that's a problem because, going back to the beginning of our talk, clinical care should be based on continuous healing relationships. That's from the Institute of Medicine. So it almost brings the conversation full circle about continuity of care. So we've learned from trying to strive for the triple aim that you need to have continuity of care, you need to have access to care, you need to track patient satisfaction, both access and communication. But what we're seeing now that's disrupting the ecosystem in the United States is that patient convenience has become a new driver. So what are we at Hopkins actually doing about this to help here in India? And we've actually partnered with HCL. So we're collaborating with HCL to transform healthcare delivery in India using a primary care patient-centered model. And we're 2 years into this. We're actually transitioning from year 1 to year 2. And there's already been dramatic improvements in operation, quality, care pathways, and provider education. There are 5 centers of the Hopkins HCL affiliation in the National Capital Region, delivering acute care, chronic care, and preventive care in a collaborative multi-specialty environment. All the clinics, as I mentioned, are affiliated with Hopkins, and there's 4 centers that are already accredited by the Hospital Accrediting Board. So how have we done this? Well, we focused 30 more seconds on improving patient outcomes with clinical pathways and electronic medical record, improving patient satisfaction, and lowering costs. And so we're very excited about what we've seen change already and what we see in the future. So I thank you for your time.
Thank you, Professor Stephen. Extremely innovative, and I believe it has tremendous potential. Thank you for pointing out also or classifying the thoughts that were there earlier into your triple A. And it reminds me of the triple A, which also has solutions. With that, let's move on to Dr. Seth's talk.
Dr. Jairam, ladies and gentlemen, it's a real privilege for me to talk on organ donation in this August forum. It was about 10 years ago that we dared to dream about organ transplants in North India seriously. And all these 6 soldiers that you see, they were dying of liver cirrhosis, and they all got new livers from people who donated when they died. And as you can see here, they not only survived, they went back to a quality of life, and they were back in uniform. And that is what organ transplantation is all about. But look at the problem in our country. We need more than 400,000 organs in a year, and the 2015 data, we have done about 17,000 transplants. And the major problem that most of our organ transplants are happening from living donors, and the deceased donor numbers are quite low. So what are the sources of organs? Basically, we are looking at 2 right now: living donors from within the family and the non-living donors. The non-living donation happens only in brain death, especially when we are starting out in our country. It's important to remember that organ donation usually doesn't happen in a normal death. It happens in a brain death. In brain death, the injury occurs to the brain so that the brain dies, but the heart continues to beat for a few hours, a few days. And that is the window that we use for organ retrieval. Brain death is death. The only difference is that the heart is beating for some time, allowing us to proceed with retrieving organs. And these are the 6 organs which we talk about routinely when we are looking at organ donation after brain death. When we talk of eye donation, skin donation, these are tissue donations which can be done in a normal death also. Now, there have been various organizations involved in organ donation in the country, starting from southern India and gradually moving northwards. But the most significant thing which has happened now since last year is that we have the government pitching in big time, and we have the National Organ and Tissue Transplant Organization with the headquarters in Delhi and with regional autos all over the country. And now this is going to be a game changer, and we can look forward to a lot more organ donations. With whatever efforts that we have been done over the last 10 years or so, you can see that in the last 5 years, our organ donation rate has become tenfold. We were 0.05 per million population 5 years ago, and today we stand at 0.5 per million population. Still very low numbers when you compare to the Western world. Spain, Croatia are about 35 per million population. But what we are aiming as a country is about 2 per million by 2020. Now, this is a very busy kind of slide, but very impressive numbers. You see, about 10 years ago, this was a non-existent slide. So if you see on the left lower corner, across the country, we've had 570 people donating all their organs. And in the right lower corner, 1,675 organs were transplanted across the country after brain death. Tamil Nadu, we all know, leads in this. But I would also like you to go down a bit along the slide and look at Chandigarh. We've had 39 donations in Chandigarh, mainly in PGI Chandigarh and the Army Hospital there. And they have shown us a more than 30 per million population organ donation rate. And what it tells us is that as people, we are not bad. We like to donate. We are very altruistic, but we have not tried enough. And whoever has tried so far in the country has succeeded. And what we need to do to increase organ donation is to work at 3 levels. We need to see what the government has to do, what the medical community has to do, and what we have to do for awareness. But basically, nothing moves in this field till there is a felt need. And whenever a real felt need has happened in a system and the system has tried hard enough, we have succeeded. Talking of the government, we have now the Prime Minister who has expressed his opinion about organ donation, and that is very heartening to see. And a lot of things have been happening now in NATO and ROTO. Still a long way to go, but yes, we are moving ahead as a government initiative. We have the new law, which is really fantastic, and I'd like to show you in one slide the difference between what we had 20 years ago and what we have now in 2014. Can you see what happened? No, a lot of slides still. So basically, yeah. Earlier, brain death was possible declaration only in hospitals which are transplanting, but now we can do them in any hospital which has an ICU. Presence of a neurologist was mandatory to diagnose brain death, but now if you don't have one, we can do with other specialists. Counseling of family for organ donation was not done, but now it is supposed to be mandatory. Transplant coordinators are required in every big hospital which is transplanting, and medical legal donations after head injury have been simplified. So the law is on our side, but still we need to do lots more. In our Fortis healthcare, we started with organ donation in 2012 by making SOPs and trying to push it forward. And these are the 16 hospitals across the country where we showed it that we need to do this and take it on as a priority. And it's quite heartening that within a short period of time, we've had 37 donations across the country and 111 organs we have transplanted from organs generated within the own system. But this is to show you what happens when we actively track organ donation in our country in a private hospital, where we actually look at every brain death carefully. 27 brainstem deaths in my hospital in Gurgaon, 5 excluded for sepsis or malignancy, 22 families counseled, 7 say yes. So an acceptance rate of 30% is not bad at all. But despite 7 people saying yes, we could not take organ in 2 people for various reasons which I will tell you. So we need to talk at all 4 levels on what the actual problem on ground is. The biggest problem we have is that the brain deaths are not getting declared. And I think something is wrong with the system. Let me tell you very briefly, this is my own mother-in-law, and we ended up donating her organs. She was in a very big private hospital in New Delhi with a massive brain hemorrhage. And this is what happens day to day in every hospital across the country. The staff there didn't know that I work in organ donation, so I actually asked them that, do you think she's brain dead? And the usual answer you will get is, not yet, but maybe 90%, 95%. We need to close the loop. We need to say that this patient is brain dead, which means death, so that the grieving can start. And only then the next step of approaching the family happens. And the next thing is, does the hospital have a brain death committee? And nobody knows. So we do not have the processes in place. So we had to shift her on a ventilator to another hospital which had a brain death committee. And now her vitals were crashing, but then you find that the driver of the ambulance decides to stop and have a cup of tea. So these are the kind of problems which we are facing in day to day in our country. So what we need to do is report all brain deaths. We are not even reporting 1% of the brain deaths that actually happen. And we must approach all the families once there is brain death. Next problem is counseling. Counseling a family which is grieving requires trained staff. And unless you have a trained transplant coordinator, the family is not going to accept the organ donation. And again, we have been doing our bit in training about 60 to 70 coordinators in the month of April every year in our own system. Most difficult is the acceptance from the public. This is what a monitor looks like, that the heart is still beating, but we are saying that the patient is dead. So this is again very, very important that we do awareness, and we have done now a huge campaign, the More to Give campaign that you are watching all the time, by involving the celebrities, etc., so that there is more awareness happening. And there is no religious taboo on this. We have discussed with all religious leaders, but instead of saying that our religion is okay with organ donation and being passive about it, we want the religious leaders to step up, take the mic, and then talk about organ donation, and that is something which has not been happening. I'll skip a few slides to get on to it, that without the police we can't do anything in this field. And medical legal donations, people talk about. This was a patient who got shot in Meerut in the head. You can see on the CT scan there's a bullet there, but we were able to, he came to Delhi for treatment. There was a murder, there was UP police, there was Delhi police, but still one could get the sanction for organ donation. So without police involvement, in our country we use green corridors to transfer organs. So the police people have to be on board if we have to do any kind of organ donation. And this is where we are actually going wrong in the country. organ donation is happening only in about 7 or 8 states where the transplantation is happening, and 95% of the transplant activity is happening in private hospitals. So we need to have this whole map green, and we need to have at least kidney transplant in every state in some major government hospital so that the common man benefits. And of course, when people go to make their driving license, we have started in Chandigarh, we started in Karnataka. That is the time we ask them, would you like to talk about organ donation like it is done in the United States? So this part is another thing which has to carry on. Last few slides. We need to do whatever we can to promote at various levels. And what we can do in this audience, the august people who are here, we must start by pledging to donate our own organs. You know, we have 400,000 people who need organ transplants in a year in our country, but when we talk to their families, none of them have actually pledged themselves. We all want things for ourselves. In fact, we had a family where somebody had a kidney problem. They were looking for a kidney donor, they could not get. The patient had a brain death with a hemorrhage, and the liver was good. And we asked the family, would you like to donate the liver? And they said no. So what we do in our country is we want everything, but we are not ready to give. And that mindset we have to change. So we need to pledge our own organs and then talk of organ donation. We must find out whichever hospital we are working in, whether we have a brain death committee. If we are a smaller hospital, it doesn't matter. You can apply for a non-transplant organ retrieval center. Have a system in your hospital where you are actually watching, unless the hospital administration is watching that there is a brain death, the clinicians, the critical care people may not declare brain death and never go to the next level. And also the brain dead people, gradually the quality of organ goes down with every passing hour. So unless the critical care team is maintaining the organs with a standard protocol, the organs don't last. So that is very important, and all of us must try to participate wherever we can. I feel as a nation we are very capable of doing this, and if Spain has a Castile festival, we have our own Dahi Handi, and if Spain can do it, I'm sure we can also do it. Thank you, ladies and gentlemen.
Dr. Seth, thank you very much. I'm sure that everyone is aware of the importance that transplant has today in our country. And I quite agree that we have not done enough. The law is on our side, irrespective of what the newspapers may have told us over the last several weeks. And we need to join together in this endeavor. No transplant program can happen in isolation. It cannot be a single corporate, a single group that can move this forward. If all of us unite, we will do substantial benefit to the nation. This is a point that I wish that every one of us ponders and looks at how in our respective areas we can work together and not in isolation. Therein lies the future. Ladies and gentlemen, we are behind schedule, and therefore I am reluctantly not going to allow any questions to the speakers. However, I gather and I'm sure the speakers will be with us at lunch, and those of you who wish to converse and seek clarifications, please feel free to do so. I've had nods from all the chiefs. Thank you, and good luck.
Ladies and gentlemen, a big round of applause to our keynote speakers. Thank you so much. We now break for lunch and we reassemble back at about 1:30.